This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome, everyone. Welcome back to another episode of the Not Your Doc podcast. I'm your host, Vanessa, and I'm here again with Mr. Not Your Doc himself, Dr. Charles Tadros. How are you today?
Very well, Vanessa. It's nice to see you again. Another gorgeous day in St. Louis.
Oh my gosh, yeah, we've been spoiled. I have a feeling, November is next week, and I feel like the weather's going to shut it down for the year.
Yes.
It's going to be dreadful.
At least no more lawn mowing, some leaf picking for right now.
That's true. Yeah, but it's going to be good. Okay, so today we're going to bring you another medical topic from Dr. Tadros, and that is high blood pressure. Mm-hmm. So before we get any more into it than that, I encourage anyone who's thinking to themselves right now when they just heard me say high blood pressure, I'm young and healthy. A discussion about high blood pressure won't be relevant to me. I encourage you to keep listening. I know as a lay person, a non-medical person working in a medical practice, I've been shocked, honestly shocked to see how many seemingly young and healthy patients that find out for the first time when they start seeing us that they have high blood pressure. Mm-hmm. It can happen much earlier and younger than you expect. If you're a person that's already aware of your own blood pressure issues, or if you know you have a family history of high blood pressure, also keep listening. One of Dr. Tadros' biggest strengths, in my opinion, is his ability to explain conditions like this, not only in a way that makes sense to the average non-medical person, but also helps us understand what we actually need to do, what actions we should take with the information. So you're who I want to teach me about high blood pressure. Okay, yeah. So I need to offer up a confession, which is that all I really know about high blood pressure is that it's connected to stroke.
Yes.
Like, that's it. So, and I have a feeling that there's more that you would want us to understand about blood pressure than just that. So,
sure.
Can you start off with what blood pressure is, and then broadly why everyone should continue listening to this discussion about it?
Well, thanks. Thank you, Vanessa. High blood pressure, well, we'll start with just blood pressure. Everybody has blood pressure. You have to have blood pressure in order to survive, in order to exist. Blood pressure is just the force from inside the blood vessels. These are conduits. These are pipes that run around your body, attached to your heart, to push blood out from your heart, and it circulates all the way around your body. It's a closed system, and it comes back to your heart. And it's just what the pressure is on the walls from the blood flow from the inside of the walls pushing outwards. And
so is it a measurement of like how hard the heart is pumping and and then contracting?
It is.
Or contracting and relaxing?
Right. It's in part a measure of that, but actually it's more a measure of what we call peripheral vascular resistance. So it's actually how much pipe you have. So as you can imagine, the more pipe and the smaller the pipe that you have, the more pressure on the walls if you're trying to squeeze the same amount of volume.
Okay.
And so blood vessels are throughout the whole body. Like I said, the big hose that starts out of your heart is called the aorta, where the blood comes out of the heart to the rest of your body. This is the only way it really comes out. And from that aorta, all sorts of branches go up to your neck, into your brain, into your eyeballs. And so from the aorta, blood vessels go to your spinal cord. And from the aorta, blood vessels go down to your arms. And from the aorta, as it goes down in your chest and belly, blood vessels come out to the kidneys and the intestines, and then eventually the aorta finishes off in your low abdomen, and you have blood vessels go down to your legs. And
wow, it has to travel a long way to get down to your toes, huh?
Yeah, that's correct. So we actually have miles and miles and miles of blood vessels throughout our body. We actually measure peripheral blood vessels. So this is in your arms typically. You can actually measure your blood pressure in a variety of places in your body, but typically for primary care and outpatient medicine, it's typically measured by blood pressure cuff on your arms. In hospital settings and ICUs, we can measure in other ways with other monitors inside your blood vessels, actually. central blood pressure monitoring through certain catheters. And we could get readings other ways with ultrasound and stuff like that. But the typical way that most people interact with their own blood pressures, how they get to know about their own blood pressure numbers, is through blood pressure cuffs. And we can come back and talk about that.
Sure. So I know a typical blood pressure reading is made up of two numbers, right? Like someone will say your blood pressure is 120/80.
That's right.
What do those two numbers mean?
Yeah. So if you can imagine, this is 120/80 millimeters of mercury of pressure, and you're like, well, there's no mercury in my blood. What are you talking about? Well, it turns out in the old days we could and we still have some of these. We don't see them too much, but we actually had columns of mercury, and you can actually watch the column of mercury try to balance itself out against your wall resistance, your wall blood pressure. So it's actually measured in millimeters of mercury, and whenever it's 120/80, it's 120 millimeters of mercury. Height, you actually is 128 millimeters from, let's say, you have a tube of mercury attached to a flexible tube that goes to a blood pressure cuff around your arm, and actually it's how high the column of mercury goes. So whenever your heart's squeezing, your blood flow comes out to your arteries in your arm. And what happens is that you can sense that the way we do it with blood pressure cuffs, all the way to attach to a column of mercury. And as the heart squeezes, the blood pressure is higher temporarily for a fraction of a second. That's the 120. And as the heart relaxes, your blood vessels collapse a little bit. They're elastic, so they collapse a little bit. And that's the 80. That's when the lower number. So 120 is the higher number, and the 80 is the lower number. That's kind of the peak blood pressure that your arteries will see, and the lower blood pressure that your arteries will see.
Yeah. I was thinking about millimeters of mercury, and that's actually how we still measure barometric pressure in the atmosphere, right? Okay,
Yes.
So this is kind of a similar concept. That makes sense. So I know the words diastolic and systolic, which is the top number and the bottom number, right?
It's the systolic is the top number, and the
Systolic
diastolic
is the top number.
Right.
Okay.
Yep. So systolic over diastolic, and so sometimes it's like a division problem: top number, bottom number. Sometimes it's side to side with a slash sign,
Sure.
but that's right. Systolic is the higher of the two numbers, and diastolic is the lower of the two numbers, and it tells us the forces that your arteries are feeling.
Yeah.
And that's really what it is. It's an old-fashioned technique that it's still very effective and helps us understand some risks that come from too high and too long of a high blood pressure.
Sure. Okay, so I just want to check my understanding on this again. Measuring blood pressure is actually measuring the force against the walls of our blood pressure or of our blood vessels.
That's right.
Correct?
That's
okay.
right.
All right. And the top number is that the maximum pressure that our blood vessels will experience when the heart pumps.
Right.
And then the lower number is sort of like when the heart is most relaxed before it pumps again. Is that correct?
That's right.
So that's a range of pressure that the walls of our blood vessels are experiencing.
That's correct. Yes.
All right, cool. All right, there we go. So, okay, so now that we know like mechanically how it works, can you answer for us this? Can I tell if I have high blood pressure based on how my body feels, or can I tell if someone has high blood pressure just by looking at them?
Right. That's a very common misconception. I mean, whenever I was young, I remember TV commercials coming on calling it the silent killer, and we still call it the silent killer because sometimes the first sign that you have blood pressure problems, hypertension, is a stroke or heart attack or kidney failure. So it's silent and that's why you have to have it measured. You can't really feel it. Now, people mistake high blood pressure by looking at somebody who's sweating, or somebody who's red-faced, or somebody who's got bulging neck veins, or somebody who's got a little bleed in the white of their eye, their subconjunctival or scleral hemorrhage, and they interpret that as being a sign of hypertension or high blood pressure. And the answer is not, almost never. So that's why you really can't wait for any outward symptoms or signs. You have to actually go chase these numbers down and keep track of them, because blood pressure changes naturally over the course of your life.
Right. Okay, so I know you're going to define for us what hypertension is. Can you say, because I know that your blood pressure can increase from certain activities or whatever, but there's a difference between that momentary increase to where it's technically high or elevated blood pressure versus the disease hypertension.
That's
Can you
right.
talk about the difference between those two?
So, like I said, everybody has blood pressure. We all have to have blood pressure. We all have numbers that tell us how much force our walls of our arteries are experiencing. But the disease of elevated blood pressure, or better known as hypertension or benign essential hypertension, that's what we typically. That's when it's a disease state. First, let me talk. Let me start saying. We'll talk about the vast majority of people who have benign essential hypertension. There's a small number of people who have high blood pressure, elevated blood pressure, persistently elevated, over several readings, over several days to weeks. That you can call it, you can call it the disease hypertension. And there's a small number of people, younger than 18 typically, that are found to have elevated blood pressures that are really hypertension. And those people are very special. We won't talk about those too much. That's why pediatricians you'll check your blood pressure, not very often in kids, because we can pick up kidney disease and certain endocrinological or hormone-related diseases and certain congenital blood vessel abnormalities that sometimes kids are born with that lead to hypertension. So that's a very special case. These are typically kids and youngsters and teenagers that are eventually found to have hypertension. They're not our typical adult who have hypertension.
Got it.
So that's the first thing. So yes, so the elevated blood pressure above, turns out anything above 120 over 80 for the vast majority of us, now not everybody, is potentially something that needs to be rechecked relatively soon, within weeks to months. So that's the first thing. It's much more complicated than that, but I want somebody to picture in their mind's eye 120 over 80 for the vast majority of people that are going to be listening to our podcast. That's what we're going to be targeting. There are people who are diabetics and people very elderly that would probably be allowed to have a blood pressure higher than that, 130 over 80. People with kidney disease, diabetes, or elderly can be allowed to be higher than that. But most of our people that we're going to be listening to this podcast will be 120 over 80 or under, or less than 120 over 80, I should say, not just 120 over 80.
Sure. Okay, so if I am exercising, for example, if I am running as fast as I possibly can, my heart starts pounding,
right,
and I can feel my pulse increase. Does my blood pressure increase
That's
when
right.
I'm exercising too?
That's right.
Okay, so so it's not hypertension just because I have a blood pressure
Right.
over 120 over 80 at a point in time.
Right.
When does it become problematic?
So when you take the blood pressure is important, but you're correct. Thanks for bringing it around again. It's normal, it's expected if you're under stress, in pain, or exercising to have elevated blood pressure. That's a temporary thing, minutes to hours sometimes. Pain or anxiety or early part of hemorrhage, for instance, if you're bleeding from an accident, early part of hemorrhage, we expect your blood pressure to be higher. That's appropriate, but what we're really talking about is people at rest that get the blood pressures checked at home or in the office, in the doctor's office. That's what we're talking about. So these are typically multiple readings, not just one, but several readings, oftentimes in different places, home and office, that are consistently above a certain level. Like I said, 120 over 80 for most of us. For certain groups of people, they're allowed to be higher than that. So that's correct. So pounding heart rate, whenever you grab your laundry, run upstairs, pounding heart rate for a high pulse rate, but we expect also elevated blood pressure. But we expect it to come back down, both the pulse and the heart rate, with the pulse, which is the heart rate, and the blood pressure. We expect that to be down in 15 minutes, let's say, after running up the stairs.
All right, that makes sense. All right, so I want to know what counts as high blood pressure.
Sure.
Can you talk more about these? I'm referring now to an infographic again that we will link in the podcast description. This is from the American Heart Association, and it talks about the categories of blood pressure. So can you just go through with us here? We talked about normals, less than 120 over less than 80.
That's right.
What do we see? What are the different categories and stages of high blood pressure after that?
And by the way, this is whenever they do recommendations or when they do research, it's important to kind of listen carefully, because it's not 120 over 80 like we said. It should be less than 120 over 80.
Yeah, that's like the max good one.
So
okay.
it should be less than.
Yeah.
So normal is considered less than 120 over 80, 120 millimeters of mercury over 80 millimeters of mercury. That's considered normal. Elevated, and this is once again seated, and we can talk about what it takes to get a good blood pressure reading, whether whether at home or at the office. Elevated is 120 to 129. And then the bottom should be less than 80 still. So the top now, so it's elevated. If the top number is elevated by 10 points compared to the normal, the bottom is still less than 80, and that's considered elevated.
Yeah.
And then we have 2 stages of hypertension. So this is when we start thinking about treating people with medicines, and we'll come back to that. But high blood pressure, stage 1, is called hypertension, is 130 to 139. 130 millimeters of mercury pressure to 139, or a bottom number between 80 and 89.
So a too high top number over a normal bottom number is still problematic, and vice versa?
That's right.
Okay.
So the first 2, the normal and elevated, are both of them have to be in those ranges. The stage 1 hypertension starts with the or.
Okay.
It's either stage 1 is either 130 over 139 or 80 or over 89.
Okay.
So that's stage 1, and we'll come back to that. And stage 2, as you can imagine, is even higher. It's a blood pressure of 140 or higher, or a bottom number of 90 or higher. So there's a pattern here.
Yeah.
There's a pattern of 10 points. You can notice from normal to elevated to blood pressure stage 1 is 10 points. It goes by 10-point increments. So, and then more severe cases, and these people sometimes can run around without any symptoms also, is called hypertensive crisis. And that's higher than 180 for the top number and or higher than 120 for the bottom number.
Yeah.
So that one, and even then, these people may not be feeling it, even though it's considered crisis level.
Wow. Okay, so it's good to have those definitions. You said you were going to tell us about, screening for high blood pressure. How do you get a good blood pressure reading? And if there's say you're in your doctor's office and an elevated one is seen there, what are they going to recommend that you do to follow up to get a good picture of what your average resting blood pressure is?
Yeah, so if we're taking blood pressures in arms, and I've talked about mercury, which we know almost nobody uses anymore, so it's a different type of blood pressure cuffs. You won't see a column of mercury type of blood pressure cuffs. You'll see something called aneroid, which is a dial one typically, or electronic blood pressure cuff. What they'll have you do, typically the ideal way to get a blood pressure check, so you can know, so if you can get a reproducible one, most accurate one, is that you will be seated with your both feet on the ground and your arms by your side. That's the first thing. Not leaning forward. That's the next thing. All these things can alter your blood pressures, blood pressure readings. If you have long sleeves, that should be your arm should be out of long sleeve. It should be the blood pressure cuff should be on bare skin or short sleeves. You should have your bladders empty. Turns out full bladder, leaning forward, not resting for 10 or 15 minutes before you take a blood pressure reading. Make a difference. Sometimes a slight difference, sometimes a significant difference.
Sure.
Oftentimes, some people will not want you to have caffeine right beforehand for the few hours beforehand, etc. But those are the big ones. Both feet on the ground, arms at heart level or left atrial level, bare skin or short sleeves. And the blood pressure cuff has to be sized correctly. That's another popular thing that happens is that when we buy electronic blood pressure cuffs, they tend to come with one size.
One size, yeah.
So that's one of the problems. So a lot of the blood pressure cuffs nowadays have markings that show what size arms it can go around. But the bladder, there's a Velcro piece, but the bladder, that's an air bladder that you pump up and squeeze close your blood flow temporarily in your arm. The bladder should encircle your arm at least half and oftentimes 2/3 all the way around.
Okay.
So if you have a bladder that encircles all your arm, that's too big.
Okay.
If you have a bladder that encircles only a quarter of your arm, that's too small.
Sure.
And that also can give you false readings. So there's kind of a bunch of little rules that add up to can give you either accurate or inaccurate, depending if you follow the rules or not.
I know that we definitely see this like in our patients. If someone rushes in for their appointment and they've been in traffic or whatever, and they come in, and first thing we do is take their blood pressure.
Right.
It's likely to be much more elevated at that point than when we take it again at the end of their appointment, right?
Part of the problem with any doctor's office is that they're on a kind of a schedule, and to technically do everything correctly, you're right, they a patient would have to empty their bladder and go sit in a chair or be recumbent in for 10, 15 minutes, correct size cuff. Sometimes if it's elevated, they're repeated immediately right then and there and take an average of 3. Or sometimes they'll have you wait and a few minutes and come back in and read it, or take it at the end of the visit after you've been sitting for a while. And sometimes they'll have you do it at home. Obviously, you'll have different equipment than the doctor's office. I'm not a big fan of electronic blood pressure cuffs. I'm a fan of manual cuffs with stethoscopes, but I know that's very hard for the typical person to do at home. So there's ways to make sure that your electronic cuff, your Omicron or Omicron. Omron, excuse me. Omron. Yeah.
We know what's on the brain.
Yeah,
hey, COVID.
That's right. The Omron blood pressure cuffs that typically are available electronically for $35 are pretty reasonable if you have the right size cuff and you follow the instructions. And you can measure it against, you can gauge it against your office cuff. You can bring it into the office. The doctor could take theirs. You take yours with your home machine, and they should be fairly close.
Okay. That's good to know. Okay, so now that we've kind of talked about like the nuts and bolts aspect of blood pressure, how it works, what the readings are, all that kind of stuff, I want to talk about the things I think are going to be more impacting on the people listening to this. Number one is who will be affected by high blood pressure and when, and then also what are the impacts on the body.
Sure.
So let's talk about who will be affected by high blood pressure or hypertension.
So the typical hypertensive person that we see, the typical benign essential, the most common cause for hypertension, once again, not the congenital, not the kids and the preteens and teens, that would be unusual to have hypertension, and that's why they have to have special checkout to make sure there's nothing else going on. So the typical person that we end up seeing typically is in their late 20s, early 30s. Typically because they stop getting their shots and seeing their pediatrician once they finish high school. Yeah. So typically we don't see them for college in the first many years after college, and then we start seeing them late 20s for certain reasons or early 30s, whenever they start having families and stuff like that, having to get life insurance and stuff like that. Then they start showing up. But oftentimes these people have had, because of drinking, smoking, overweight, may have already had elevated blood pressure for years before they ever show up. As a natural part of their getting to know their physician.
Sure.
So youngsters aside, those are special cases. Pediatricians and take care of those, and family medicine doctors who take care of pediatrics. But that's important to check. But usually we start thinking about checking 18-year-olds and above.
Okay.
Certainly if they don't have any big risk factors, they're not smoking, they're not drinking, they're not obese, it doesn't run in their family, you can do a blood pressure check at age 18. And if everything's fine, they don't have any risk factors, family history, et cetera, you can check them again in 5 years. If any of them is even borderline, then they typically will be checked within a few months to a year. So that's pretty reasonable. And once again, typical blood pressure check, if you sit down for 10, 15 minutes, is only, it's less than 60 seconds to get it done.
Sure. And
you have that number, you stash it away in your phone or wherever, your medical record, and you can compare. And that's important to be able to compare accurate ones.
Sure.
And that'll give you a hint about what's happening. And that's not the only thing, but that's the start. Sure. And certainly if anybody who has hypertension who is being treated, they're going to be checked several times a year to make sure there's no medication adjustments, et cetera, or if they gain a bunch of weight or something else changes in their lifestyle, then they should be checked. Some people lose weight. Sometimes they need to be decreased on their blood pressure medicine. So, yeah.
Okay, so it sounds like, basically 18 and over is the right time to start screening for high blood pressure.
Right.
And people can present with high blood pressure, elevated blood pressure pretty much at any point in their adult lives, depending on what their lifestyles are like, right?
That's right. And people think that by looking at somebody because they're thin or they don't smoke that they must not have blood pressure, they must not have cholesterol problem, they must not, and the answer is or heart disease, it's totally incorrect.
Wow, yeah.
So certainly if you smoke, drink, and are overweight or significantly overweight, it increases your risk, but it doesn't mean that you don't have any risk whenever you're thin and don't smoke and don't drink and or exercise.
Right.
Yeah.
Are there certain groups of people who are more susceptible to hypertension, either due to age or race factors?
Yeah, well, certainly you and I were talking about this pregnancy. So the good news about women in pregnancy is that they're watched very carefully
Right.
for many months, and that's so PIH, pregnancy-induced hypertension, oftentimes second or third, typically third trimester, so oftentimes these people don't have a blood pressure issue beforehand. May have significant weight gain, fluid retention, et cetera, or may not have any of that stuff and still have hypertension. They have different limits. They have different number targets for women when they're pregnant, by the way, not the same targets as we listed here. And that's a very special case. The other group of people, the elderly. So the elderly also. So as we grow older, our elastic blood vessels tend to be more rigid.
Yeah.
A little hard, quote unquote hardening of the artery. So you lose elasticity, and so that tends to happen as we grow older. And older for us, by the way, people are probably in your 40s and above. People think, well, somewhere, my grandfather's. Nope. We like to remind people that we will, some of the elasticity issues that start going away probably late 30s into your 40s.
Did you hear that, y'all?
Yeah.
Your arteries and blood vessels can lose elasticity starting in your 40s.
Yeah, and even if you don't smoke, and drink. By the way, this is the same with our tendons. This is professional athletes. That's why we don't have This is why if you try to be weekend warrior, you snap,
Sure.
pop your tendon, your Achilles tendon,
Yeah.
because we lose a lot of elasticity.
Yeah.
Your skin,
Collagen
right?
starts to-
Collagen and et cetera. Yeah. So it's important for people to recognize that.
Okay.
And then other groups are African Americans, well, blacks, because the black ethnicity, they can come from Africa, they can come from Caribbean, other places, sub-Saharan Africa. So those people, those groups of people are at increased risk of getting hypertension. They're increased risk of other things that also can lead to hypertension. We can come back to that.
Do we have any idea why that is? Is it, just certain ethnicities tend to be more prone to different types of conditions, or is there?
Yeah, so it turns out in the United States, probably about 58% of blacks, this is coming from whichever country of origin, develop hypertension.
Yeah.
Whereas Caucasians, the whites in the United States, probably closer to 48%, 48%. So it's more prevalent in the black population, and it's also, and we think in part is partly the renin. This is one of the systems. This is one of the hormone systems, the renin-angiotensin-aldosterone system, which deals with fluid retention and salt retention.
Okay.
Is maybe more sensitive, and that's why we oftentimes will offer both elderly folk and black folk more likely to offer them diuretics and a calcium channel blockers. It tends to work better in those two groups of people.
Okay, so just kind of one of those physiological differences
Absolutely.
between different genetic makeups.
That's right.
Or whatever, heritage.
That's right.
Okay, so that's really interesting. So so certain groups of people, regardless of lifestyle factors, can be more susceptible. Age takes a role. Obviously, smoking, drinking, overweight, that kind of thing, diet, all of that takes a role. So once someone has established that they have high blood pressure, hypertension, what are we looking at for treatment?
So all the stages, elevated, if that it becomes stage 1 or stage 2 or a hypertensive crisis, all stages need to have some long-term lifestyle changes. Oftentimes, whether it's weight loss, decrease alcohol or stopping alcohol, stop smoking. There's no safe level of smoking. Those are certainly the big things that are modifiable lifestyle risk factors. So that's the first thing. Some people need medicines right away. So typically, certainly stage 2 and hypertensive crisis, you just don't want to stop it. Watch what you eat more vegetables, et cetera. We'll talk about the DASH diet. So oftentimes with stage 1, they'll start either with diet and exercise and then bring them back in a couple months, or oftentimes they'll start diet and exercise and start one medicine. By the time you're at stage 2, 140 millimeters of mercury on the top number, or 90 millimeters or higher on the bottom number. On stage 2, they're already starting on 2 medicines at the same time.
Wow.
Plus lifestyle changes. For hypertensive crisis, these people are very special, and oftentimes they're being seen in the emergency room or inpatients, et cetera, because their blood pressure is so high they could potentially have a stroke within minutes to hours.
Wow.
Stuff like that.
Yeah. Okay, so there's different, based on the severity, basically different combinations of medications. Lifestyle changes are encouraged for everybody, and we'll talk more about the DASH diet as well. One thing that I neglected to bring up before that I had kind of foreshadowed to are the implications of high blood pressure.
Yeah.
What other comorbidities is high blood pressure implicated in?
So high blood pressure may be the first sign that there's an increased risk for diabetes. This is something that people, it's like, what does blood pressure have to do with blood sugars? They share some of the same common metabolic effects. But so it turns out that that people maybe potentially with elevated blood pressures can significantly increase their risk of diabetes later down the line. So it's the first thing. So therefore, by lowering blood pressure before the patient has full blown diabetes, it potentially it actually can reduce the risk of going on to having full blown diabetes. So increased blood pressure can lead to potentially for diabetes, increased diabetes risk, and reducing blood pressure can decrease the risk of developing diabetes.
Interesting.
So that's the first thing. Certainly strokes, like you mentioned, retinal bleeds, heart attacks and heart failure. Heart failure is congestive heart failure with fluid retention, kidney disease and kidney failure, and need for dialysis. Peripheral artery disease. These are blocked arteries in your legs where people can lose their limbs because they block their arteries. So because these blood vessels are everywhere in the body, I go brain, eyes, carotids for these are neck arteries for strokes, heart attacks and heart failure, atrial fibrillation, which is an irregular heartbeat. The number one cause for atrial fibrillation in the United States is hypertension. Atrial fibrillation is an irregular heartbeat that requires sometimes blood thinners, because whenever your heart is not pumping correctly, blood can pool and develop clots, and these clots can shoot out to your brain. And then kidney disease and kidney failure and dialysis, and peripheral artery disease. So that's the kind of, so you can see that hypertension affects practically every aspect of your body, your function.
Would it be accurate to say that high blood pressure or elevated blood pressure can be kind of a canary in the coal mine?
It is.
To point to something else more serious coming down the pike.
That's right. In fact, it's probably the most it's the most easily modifiable risk factor for end organ problems. End organs are your eyes, your kidneys, your heart, your brain, your arteries in your legs. So that's probably the most easily modifiable, whether we modify it through diet and exercise or modify it through medicines. And certainly we can access these numbers, unlike blood cholesterol, where you have to be fasting, get a blood and get an order, or blood sugars where you have to prick yourself. Blood pressure, you put your arm in a blood pressure cuff and you can get a pretty reasonable number. Very
easy to test for. So I know you said that identifying and then controlling blood pressure for someone who is either pre-diabetic or has history at risk for developing diabetes. Could you also help to prevent either the severity or the actual start of any of the other conditions that you talked about?
All of them, right.
By monitoring your blood pressure and doing things to lower it or keep it in a healthy range.
That's right.
Okay.
I always forget to tell people, it's not that we're trying to lower your sugar so you could look better. What we're trying to do is lower your risk of having a stroke or heart attack or kidney failure. So everything that we're doing, it doesn't matter where you start, whether you start by lowering, stopping tobacco or lowering your weight or treating your sleep apnea. That's another thing. All these things can help. All these things help reduce the risk of disability and death. And disability includes strokes and heart attacks and heart failure and kidney failure and death.
Yeah.
So that's
and of
what
course these are not just like end diseases for people in their 90s. Like this is stuff that really affects people in the core of their lives.
It's at their peak peak earning potential, their peak time to enjoy their spouse, their partner, their kids. So it's a peak time in your life. You're not at the end of your life where you're sitting rocking in your chair watching everybody else have a good life. This is the peak productivity of your life.
Can you tell us a little bit? I think that I'm sort of speaking for my cohort here. Again, I'm in my early 30s. How does alcohol and nicotine affect my blood pressure, and why? How does it affect that? They seem totally unrelated, but how do they affect it?
Sure. Well, alcohol. So one of the ways alcohol affects blood pressure is certainly weight gain. So extra calories.
Okay.
So that's weight gain, and weight gain for any reason, whether you're on antidepressants that make you gain weight, or you're depressed that makes you gain weight, or you overeat, or you stop playing sports, you gain weight. Weight gain is an issue. In this case, alcohol. So whether it's the beer gut or whatever else is one of the issues. And stopping alcohol does not automatically immediately drop your blood pressure, but you can see benefits within a couple of weeks.
Sure.
And then anything else that physiologically that happens over months and stuff, you can see further lowering of blood pressure. So that's in my practice, that was one of the people that were closet drinking were one of the reasons where I spent lots of time, energy, and money trying to figure out why we couldn't control the blood pressure with multiple medicines. And oftentimes they were drinking and not telling us about it, or had restarted drinking after they'd stopped. Absolutely. Nicotine causes constriction of blood vessels. So that's the other thing that causes, and also same thing, stopping nicotine within a few weeks, you can see some potential benefit in terms of blood pressure.
Right.
And it goes from there.
It's important to say that that's a function of nicotine too, right? Not just tobacco, but e-cigarettes, anything that anything that has nicotine in it is going to be a vasoconstrictor. Is that how? Is that?
That's right.
Something that constricts your blood pressure, your blood vessels. Okay,
that's right.
Look at me with the words. Okay, cool. Okay, so let's talk about the DASH diet. So we talked about a bunch of lifestyle changes. This is something. Did the Mayo Clinic develop the DASH diet, or it just says published by them?
The government.
The government.
Yeah,
okay, awesome. Right. Can you tell us a little bit about this?
Sure, and we'll have this also on our website. Of
course.
Yeah. The DASH diet stands for the Dietary Approaches to Stop Hypertension, DASH, and it's not to be confused with Mrs. Dash, the salt substitute.
The salt-free.
Right. So
delightful seasoning blend.
So this DASH diet actually also helps weight loss too. And by the way, there are a lot of different, any way that you lose weight, and I'm not going to talk eating disorders and being sick with the flu, you potentially lose weight with those. It can also lower your blood pressure. But any way you lose weight turns out it can help your blood pressure, help coronary artery disease, etc. So a lot of the things that shorten and make your life worse in terms of morbidity, sickness, and mortality.
Okay.
But it turns out the DASH is high in potassium, calcium, magnesium, fiber, and protein, low in saturated fats, and low in sodium.
Okay.
So a lot of the stuff is going to be fresh vegetables and lower saturated fats and lower sodium. And so once again, everybody, sodium is we automatically have a taste for sodium from infancy.
Right.
It's part of our nature. But we all become used to different levels of sodium, so that if you take a break for several months from adding salt, and then you have just a natural a little bit of salt, you're super sensitized to it.
Right.
So people think, well, it tastes bland, etc. But if you give yourself time, it becomes kind of a new normal. And it's acceptable. Yeah.
I know that's something that kind of ratchets up our tolerance for sugar and salt and fat in our diets is processed foods.
Yes.
So switching to much more natural home-cooked meals that are
right.
low in processed sugars, processed carbohydrates, and processed food in general, avoiding even like restaurant meals taste delicious and rich because they are loaded with salt and fat and sugar.
That's
so minimizing your intake of those things can help to reset that.
And I know you love to cook, and I think you're exactly right. It turns out that cooking for yourself, learning to cook for yourself, actually automatically can bring some of the things under control and still taste good for you.
Right.
And so I know it's the time, energy, and sometimes people feel the money, especially nowadays with some of the economic issues that we have. Groceries have gotten higher in the last couple of years. But it turns out that it's true that if you cook for yourself, you tend to have better portion control, and you tend to have more control over certain ingredients. You can spice things up differently, and decrease your sodium and still have flavor. And that I think that's part of the cravings that we have for calories and stuff, is because some things are just bland.
Yes.
And we just keep eating.
And it's not as satisfying.
Right.
Yeah.
That's right.
Yeah, one quick little tidbit I would throw out there for if you think something is missing kind of an unctuousness or something when you're making something you feel like this tastes a little bland. Sometimes adding a little salt helps, but often you're missing acid. So a squeeze of lemon or a teeny bit of apple cider vinegar or
Right.
something like that can really help to balance out those flavors.
It does.
So, and wake up the flavors in the same way that a little bit of extra salt might. So you can take that one home.
And as you know, visually, if you add a little acid and stuff to your sauces, it brightens them up. And so,
Yeah.
so that's and something that we're not taught at all is some of the presentation, some of the visual.
Sure.
We eat with our eyes first, as they
yeah,
say.
absolutely.
So what Vanessa brings in, we should probably do a whole talk about that about cooking, and because it's not old fashioned. A lot of people are into it for their foodies and stuff like
Sure.
that. They go out to eat, but they
Yeah.
also cook at home more. And I think that's a very extremely healthy trend.
Yeah. Okay, so we're going to kind of close it out here with like some takeaways, what we want people to act on now that they've heard this information. So I think first and foremost, get connected with a primary care physician or a nurse practitioner in family medicine, somebody that you can establish a healthcare relationship with that's going to help you screen for high blood pressure and then monitor your blood pressure going
That's right.
forward. Knowing your family history is really important. Do you have a family history of high blood pressure, stroke, heart disease, peripheral artery disease? Any of those things will help to clue you in that you need to be more aware of your own blood pressure
That's right.
throughout the course of your life. Routine screenings starting at age 18. And it's important for us to remember that you won't be able to tell if your blood pressure is elevated at all just based on how you look or feel. If you're thin and young and relatively active, you could still have elevated blood pressure. They're not physical indicators really to tell you.
That's right.
Learning to monitor your own blood pressure is really great. Getting a well-fitting cuff at home. Obviously, having it monitored regularly in your doctor's office. Those are all great things to have so that you can compare resting blood pressure over different periods of time. And then finally, managing lifestyle factors. So quitting smoking or e-cigarettes, anything with nicotine, reducing or quitting drinking, lowering your salt intake, lowering your intake of processed foods. Does exercise help with blood pressure at all?
Right, and I lump it in with obesity, but it's totally separate, obviously. So we should talk about that in sleep apnea. So absolutely. So it turns out that exercise, which naturally raises your blood pressure, so you can feed more blood to your exercising muscle, is normal. But whenever you rest and recover, and as you get in more shape over months, your recovery blood pressure tends to be lower than baseline. So
Gotcha.
so you start from a certain baseline, and you exercise, your blood pressure pulse go up, and then after 30 minutes after you stop exercising, your resting blood pressure is even lower.
So it makes your heart more efficient, right?
That's correct.
Okay,
That's
your whole
eventually.
cardiovascular system more efficient.
I remind people, a lot of stuff doesn't feel right or feel good right away, but
Yep.
if you're doing it, give it several months. People say, you'll feel great. Didn't you feel great for going exercise? Actually, no. I had hurt, and I'm short of breath and everything. So injury, I want people to avoid injury whenever they're exercising, because that puts you back sometimes months to a whole year, depending on how bad the injury is. Actually, regular exercises is, people talk high intensity for 40 minutes, 40 minutes, five or more times per week. But the quickie answer is a lot of people can't even bend over and tie their shoes without being short of breath. So start slowly and work your way. Yep, start slowly and work your way up.
Yeah.
And then eventually, something that we didn't learn in med school is that weight, so resistance training doesn't have to, it could be body weight against gravity.
Sure.
So it turns out that's important. So we should talk about that as another exercise and kind of understanding the high intensity intermittent training.
Sure.
Maybe some of the better ways to control weight and get cardiovascular fitness.
All right. Well, thanks so much, Dr. Tadros, for giving us this informative overview of high blood pressure and hypertension.
You're welcome.
Hypertension.
I want to remind everybody about sleep apnea.
Oh, yeah.
Oftentimes it's with obesity, but not always. It's called obstructive sleep apnea. That is one of the big causes for difficult to treat hypertension. Is that people stop breathing at night, increases pulmonary resistance, increases heart thickening, heart wall thickening. It can lead also to hypertension, and so
Interesting. And a good primary care physician is going to help you look at all these different things that might be contributing to your blood pressure. Correct.
You got it. Yes, that's important. It's comprehensive, 360 look at your whole everything from family history to your lifestyle, et cetera.
Yeah.
Thank you.
All right, awesome. Yeah, I think this was really informative. I know it's got me thinking more about, how much salt I'm eating and, be more consistent with monitoring my own blood pressure. I certainly want to prevent myself from any of those longer term consequences. And I know that I need to start thinking about it now because I'm nearing 40.
You're
when you're
ways away still.
when you start to lose elasticity in your body. So it is important to start thinking about it.
Yeah.
So once again, if you want to get involved with the podcast, if you have any questions for us or suggestions for topics, please reach out to us at notyourdocpod@gmail.com. That's notyourdocpod@gmail.com. You can find us on Facebook at Not Your Doc Pod. And you can also find us on YouTube. The Not Your Doc podcast is on YouTube and Spotify. Thank you.
You're welcome.
Dr. Tadros.
Good discussion. We'll talk some more about this later.
Yeah, this is a good straight ahead medical one. I liked
Yep.
it. All right, y'all. We'll see you later.
Bye-bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.